so that there is a surface at the top to help with my orientation and interpretation with surgical margin at the bottom. From this power, I can see that this is skin to subcutis. And I know that because I can see sebaceous lobules and hair follicles. And this is a squamous epithelium at the top with hairs. Therefore, it's skin and subcutis. That's my normal. Don't need to go any closer than that. And this has been surgically excised. And in the center, there is a lesion located in the dermis. All in the dermis, hasn't spread into the subcutis yet. So in the dermis, there is a lesion. Now I'm going to talk about architecture. Composed of basaloid, meaning blue, solid nodules and lobules of cells. These cells appear to be connected to and or arising from basal follicular surface epithelium. So it's blue, it's basaloid, it's below the surface epithelium, blue, basaloid, making these ball shapes. So at this low power, I think it's going to be a basal cell carcinoma. It's also, it's destroyed the adnexal structures on either side. See here, there's no adnexal, so it's destructive, which goes along with basal cell carcinoma. Now I'm going to move a little more closer, just to confirm my theory. I see retraction artifact around each lobule, a feature of basal cell carcinoma, and I see really good peripheral palisade where the long axis of the nuclei of the tumor cells is perpendicular to where the invading front is. BCCs, although they grow very slowly, they often have a very high mitotic rate, but they also have a very high apoptotic rate, so they grow slowly. Prognostic factors that I would look at. The type, it's not an infiltrating, sclerosing, morphic type. It looks like a solid type, solid or nodular type, and the margins are clear.
Great. Thank you, Amanda. Questions from the learners here? I'm getting nothing on chat, so we'll move right along.
Yep. And there's a Kura cloud on this, and you can practice with the 6-part answer. Yeah. I will stop share.
Great. So now we're moving on to number 2. I'm going to recreate the rooms again, hopefully randomly. And off we go. Jess, you're still having trouble with your internet?
Oh, I went into room 6, but there was no one there.
Okay, so everyone's arriving back. That's good. How did you find that one? You were okay. You recognized the cell type and the diagnosis?
I think if you go through a little bit too, just recognizing the normal structures and where are we, what tissue are we would be good.
Yeah, okay.
How do we know where we are, Diane?
We know where we are by looking at the normal parts, which is why that's always the start of any rubric. So, so people often rush to the lesion, but if you remember in the 6-part answer, you've got to identify the normal tissue first. I will share my screen and we will pop through it.
And any questions, you can just type them in as you think of them, and I'll interleave them with Diane's narrative.
Okay, so what we have here is a piece of skin. So on this side, we can see skin adnexy, and then we've got this large tumor, and then on the other side, we've got conj. So how do I know that's probably the case? So here, just rendering slowly, we've got epithelium, and then we've got hair follicles, yeah, and we've got some sweat glands. There's a bunch of hemorrhage here, which is likely to be due to the surgery. And then on the other side of the piece, just let it render a moment. We've got conj. So if we look carefully here, we've got some little goblet cells. Once it's rendered, it's just moving slowly across. Some little goblet cells, plasma cells because it's inflamed, some blood vessels, but we have got no skin adnexy. As we come up here, we've got lots and lots of sebaceous glands, which are probably like glands of size.
Diane, how do you know it's not a lacrimal gland?
How do I know this is not a lacrimal gland, the whole thing?
No, those glands that you're pointing out.
These ones?
Yes, that's right.
All right. So these glands here are full of lots of little tiny fat globules, right? And they're arranged in a lobular fashion around this expanded duct. So it would be, it is a kind of glandular arrangement, but it's the cell type that tells me it's not really, because of the sebaceous nature of these cells. Yeah. So with skin on one side and conj on the other and this characteristic shape, we know we're at the eyelid margin. And then at the eyelid margin, we've got this large purple looking tumor. And the place that it's in is it's in the dermis, okay? And it's like the tarsal plate coming through here and the eyelid muscle down the bottom coming through here. So it's quite a big exophytic, but also invasive mass that's destructive. So I'm suspecting that this is an invasive destructive lesion. And then if I look here, I want to know whereabouts is it arising from? Is it arising from the epidermis or is it arising from the dermis? And we can see here that there's still some cells at the dermo-epidermal junction. It doesn't appear to be the epidermis is streaming down. We've got cells at the dermo-epidermal junction. So I begin to suspect that this is a melanoma. And looking more closely at the cells, I confirm that these cells have got big nucleoli and they've kind of got an epithelioid look. And I know that melanomas can be spindle or epithelioid. I also know that the cell type doesn't matter in the prognosis of skin lesions. So we've got this this large dermal-based tumor that has a junctional component and an invasive malignant component. And as I look around, I can see the pleomorphism of the cells. Mitoses are relatively infrequent, but this is normal for melanoma. Okay, so I'm now pretty convinced I've got a melanoma of the eyelid, and I think about prognostic features. The most important prognostic feature is the depth, the Breslow depth. So I would estimate that this was quite deep. It's at least 5 millimeters deep. So that's a high risk prognostic factor. I would mention that I couldn't see any perineural or vascular invasion. I would mention that the margins were clear. It appears to be non-ulcerated. Was there anything else that you would mention in prognostic features, Amanda?
Mainly the Breslow depth is the
most important one. Okay, do we have any comments or questions from the team?
Can you just point out again the meibomian gland? Just sort of draw your thing around where that is. Yeah. And why has it got that huge white space in the middle?
That's
part of it.
Yeah. So so that's where it's just cutting through to the conj, actually, I think. Do you think that's a duct?
It was lined by something.
Squamous. It's kind of
large.
Coming out to the surface, probably. Yeah. It's a very big one. Yeah.
Can you explain the junctional features?
All right, so all nevus and melanoma related lesions arise at the junction of the epidermis and the dermis. And usually in melanomas, if we look closely, even big ones, we can see here that there is a residual junctional component. Now, because it stretched the epidermis over the top so much, really, I couldn't see good examples of pagetoid spread.
Oh, stop there. So one of the questions is, how do you know it's not a Merkel cell carcinoma? And
Okay, Merkel cell carcinomas, good question, because they can occur on the face. They don't have an epithelioid phenotype when you look at them down the microscope. They're small, round blue cells. They're very, very tiny. We should probably quickly look one up, shouldn't we, to show at the next break.
Okay. And the other thing is, would a Merkel be making all this brown pigment, Diane?
No, it wouldn't. Here's some brown pigment.
Brown
pigment was actually relatively hard to find.
Yeah, and some bits there are. Yeah. And they're actually in the malignant cells as well as melanophages.
Yeah. Good.
Can we see it's got clear margins without seeing more slides to see either side of the tumour? That's a good question.
Yeah, I think yes, I think it's a good way from the margins.
Yeah, you say in this slide it is clear of the margins.
Yeah.
Yeah. Of course, you can never examine all of the margins of everything. That's
no. Yeah. Okay. I'm going to stop sharing my screen. Right. Okay. And then we'll go and look at the next one, shall we?
Yes.
So let's do breakout rooms again. And okay.
So we're going to have a threesome, but that's okay.
Yeah. I'm going to try something different. Should we? I'm trying to delete a room, and I'm going to recreate the room. So there's 5 rooms now, and I'm going to assign automatically again. Here we go. Oh, that's just 2 breakout rooms. Hang on. Recreate rooms, 5 rooms.
I've got some Merkel cell carcinomas in my slide box, so I will share those later.
Okay, and I'm going to open the rooms now. So off we go with the next one. Right, I'm going to resume recording. Off we go. I'm recording all these as one block, Amanda. So.
Yeah, and then I'll put them for the appropriate.
Okay, your turn now.
Okay. Right. So for me, there are 2 sections of skin counterparts of each other. I'm just going to focus on this one here, or which one shall I pick? Doesn't matter. I'll just focus on this one here. They show similar features, and I'm just going to rotate it because it makes better sense in my mind if I rotate a little bit. So what do I see? I see it looks like an epidermal lined surface. Now, this was a question in my room. What are all these loose bits doing down here? These look like stripped epidermis, like that would have come off the edge here, but they have artifactually loose, flaky and flimsy, and they've sort of curled back and stuck onto the surgical margin. So these are just loose parts. It's not anatomically in the correct place. They're just loose parts that have stuck on. So epidermis, and the looks like dermis to me. It's got this very strange bluish purple homogeneous look to me. And when I go closer in, I can see it's got these little wiggly worms. How good is this? This looks like solar elastosis. So these are elastotic fragments of severely sun-damaged skin. So I think this is sun-damaged skin.
So Amanda, if this is sun-damaged skin, where are the skin and nexi?
That's a good question. The other possibility is it could be conjunctiva that's undergone squamous metaplasia. I would need to find some evidence of that. What's over here? There we go.
Yeah.
There could be goblet cells if they are not, because I'm looking in the normalish stuff to see where I can find any evidence of a goblet cell. Could they be goblet cells? Yes, there's one. What do you think?
I think this is conj. So there's no skin adnexy, and of course in pterygia, which if this is a bunch of solar elastosis, then we often get squamous metaplasia, don't we?
Yes, that is true.
So it can be quite hard to tell the difference between the two, and you've got to. I think if there's no skin adnexy and there's lots of solar elastosis, we need to presume it's probably a pterygium.
It could be pterygia. And then we're going to have a look along, and you see how dense this homogenization is underneath. That's all abnormal with damaged solar elastotic cells. Okay, so I can see in the center there is an expansion of the epidermis to at least 5 times the thickness of what I think it should be the normal area. And let's have a look at the components of this. It still looks to be squamous cells. However, when we were looking in our breakout room, we found mitotic figures. This is parabasal, but there was also a abnormal mitotic figure. Actually, I'm not sure if that's a piece of dirt or not now, looking at it closer myself.
It's a tripolar one I can see, like
we were wondering if this is a tripolar mitosis. If it is a tripolar mitosis, then that brings to my mind, is this dysplasia? Because atypical mitotic figures, thickened epidermis with irregular distribution of the nuclei in a severely sun-damaged surface, a squamous intraepithelial neoplasia is what I'm thinking. Actually, what's that up there? With parakeratosis on the surface. And here we go. We can see quite an abrupt change. This is normal on the left here. And then you see there's almost a line here where it becomes abnormal and the color changes. So I think this is a squamous dysplasia. Then it comes to the grading features. How do you like to grade them, Diane?
So I grade them in terms of how far through the lesion the basal cells are, just like I grade the cervix, and how far up the mitoses go. I actually found this one quite hard to grade. And I got various opinions from the groups I popped into between grade 1 and grade 3. So I just want to reassure everyone that recognizing that this is a conj and a squamous in situ lesion, you would pass this slide, no doubt. And the grade is like the extra bit that we do.
Here are some more dysplastic features, like these multinuclear cells here.
Yeah. So if we look at the little papillary bit just off to one side there, I think that was the worst part.
This part here, the papillary.
Yeah. Yeah, and a lot of people were looking at the other one quite a lot. And just on my right-hand side of the papilla.
Down here.
Yeah, just there. It's quite thin and looks it looks like it's going into high grade, doesn't it?
Up here.
Yeah, so I think this lesion shows a variety of degrees of dysplasia, ranging from low grade in that other piece through to high grade just there.
Yeah, this is a dysplastic nucleus, and it's in the upper half of this.
Yeah.
So how do we know it's not just a papilloma or a hyperkeratosis?
Yeah, I think that the hyperchromatism, the pleomorphism, and the nuclear, and the mitoses above the base are the giveaway.
Pleomorphism, what do we mean by that? Oh, look at this.
I'm just getting a question here. All right. What are the dots and specks on the surface cells? I think we're talking about the parakeratosis.
Yes.
So there's, yeah, off you go.
Oh, well, there are long ones and there are round ones, right? So as a squamous cell undergoes normal maturation, they should lose their nucleus and become anucleate squames. Here, as the squamous cells are abnormally maturing, they are retaining their nucleus, and this is called parakeratosis.
Then I've got a question. Do we grade CIN via depth or via severity of dysplasia?
Those two are related. So
yeah. So if it was really, really severe dysplasia and still maturing normally, I would probably describe that. I'm just thinking, I'd probably, it depends what was abnormal maturation, because I think like just like on the vulva, I think you can get differentiated in situ changes in the conj. So I would if there was severe dysplasia on the base, I would mention there was severe dysplasia on the base. Would that put an increased risk of invasion? Yes, it would. I think it can be graded on both, actually.
Yeah.
I think there's probably two. This is a good research topic. I think there are two kinds of high grade in situ OSSN. One is a differentiated kind with really, really severe basal dysplasia, but keratinizing over the top. And the other is the traditional kind where we have basaloid cells going through the full thickness. But that's not been well explained in the literature, so I would just describe it.
Yes. The situation you're describing is a problem of precision rather than accuracy, in that the description of the variants is not well defined.
No, I think there's work to be done there in pathology, but I think if you just identify it and call it an in situ squamous lesion with severe dysplasia, then that will be good enough, or an in situ lesion with full thickness dysplasia, that would be good enough.
You've got to mention the word dysplasia, and that's the key word.
Yeah, and the next question is, are there any intercellular bridges? I think there were.
Oh, yeah, quite good here. Okay, here's some. So this dysplastic nucleus with 3 nuclei and 3 nucleoli is surrounded by a white space with the little prickles, which represent the remaining intercellular junctions held together by desmosomes, which are little spot welds, which make the legs of the prickles. And yes, there are intercellular junctions, prickle cells, which is a feature of squamous cells, squamous differentiation.
So another question, what about the melanin there on the right of the top lesion? So the right of the lesion that you're in at the moment. There is a little bit of melanin there. So
Yes,
you guys, yeah, you guys will know why conj is pigmented. Do you think this could be physiological pigmentation? It's a good example of it, I think.
Because we have, so the melanin is in, well, it'll be produced by the melanocytes, which will be dotted about every 5th cell along the bottom. Maybe that little fellow there.
Yeah, I think that's one. Yeah.
Yeah. But actually we can see the melanin has been transferred into the squamous cells. So it's transferred into the squamous cells as it does.
So this is why BCCs and seborrheic keratoses are pigmented. So I think this is physiologic pigmentation.
And the other places, you see it's down here, it's fallen into either a dendritic cell or probably melanin incontinence. As it's become disrupted, melanin has come out and it's in the subepithelial stroma.
Are we going to have a 5-minute break now?
Okay, have we done our section on those?
No, we haven't. We could keep going. This is what we've got. Should we do the one more?
Okay, because that will make a logical break then.
Okay, I'll pause the recording. Okay, so here we are with the fourth slide. So what did people have problems with this one?
Type them in or ask them directly. No questions yet.
So I know the group issue. The group I was in had problems with anatomy and knowing where they were.
Yes, also identifying, is it skin or not?
Yeah.
Because is the skin with a skin adnexy? That was.
Yeah, so that was a big question for my group as well. So it's non-keratinizing epithelium. Yeah. And it does have like these glands in it here, but we're going to have a look at what type of glands those are in a moment, but they're not arranged like normal skin glands. So normal skin glands, you have a sebaceous gland and a hair follicle coming out and then a bit of a gap and it's doing it again. Whereas here we've got these big lobules of glands, haven't we? So we're going to have a look at that. But first we'll look at the epidermis. So in the epithelium here is non-keratinizing and it's thin and there are goblet cells. So that confirms for me that we are in the conj. And also these glands here, some people thought these might be the abnormality, but one of the key things that was a giveaway to me is they're in quite neatly encapsulated lobules. And then there's this big thing here that looks different to all the rest. So that was what drew me for that being the abnormality. Let's have a look here. So these are little glands. They are lined by 2 cell layers and they have lots of inflammation around them. So that means to me they're one of two things. They're either either sweat glands, eccrine or apocrine sweat glands, probably eccrine ones, or they are minor lacrimal glands. Okay, and they're quite big, aren't they? So I think that these are minor lacrimal glands that are inflamed.
Yeah, is that the same as an accessory lacrimal gland?
Yeah, an accessory lacrimal gland, yeah. And then over here we've got the abnormality, which is got lots of these fat spaces in. And as soon as we see these big fat spaces.
How do you know they're fat spaces?
Good question. We know they're fat spaces because they're clear. So what happens when we process tissue is all the fat washes out of it and it forms a clear space. So when they're like this, we know that we've got spilled fat there. And if we look closer to that, then we can see that we've got histiocytes around it. And how do we know that they're histiocytes? So histiocytes have, I'm just trying to get closer, but I can't get closer. Histiocytes have got these sandal in the sand type nuclei and lots of eosinophilic cytoplasm. And are often associated with these things here, which are the giant cells. So this is a giant cell to a foreign body reaction, which is the spilled meibomian material. So this is,
aren't they pleomorphic looking? How do we know it's not a sebaceous carcinoma?
yeah, good question. So sebaceous carcinomas originate from sebaceous glands, and there aren't any about. Oh, there's another lovely giant cell here. But they're often associated with the epidermis. Yeah, the sebaceous glands. I'm just thinking here. The sebaceous glands have cells in them that, if we're lucky, have got that really, really finely divided fat in them, rather than the giant globs of fat here. Have you got any other tips along those lines, Amanda?
I think the giant globs of fat tell me that this is. I can see a lipogranulomatous reaction. This is what
this is exactly what it is. Yeah.
And I thought there was a really good nodule. This one's a bit confusing. Up on towards the margin, towards the other side of the up there. Those two. Yeah, that one there. That's quite a good little example.
It is. This is a really great granuloma.
Yeah.
Yeah. And so granulomas, as I've mentioned, are a common thing that they are asked to describe about. And they are epithelioid histiocytes and giant cells in a discrete nodule. And we've talked about granulomatous inflammation before. This is another little fat globule, and these are some lovely giant cells here.
Lipogranuloma.
Lipogranuloma. And the most important thing is not to confuse it between granulation tissue and pyogenic granuloma. Is everybody clear on the difference between those?
They are
Tell
confusing.
me if you're not.
Because they are. Right, the chat is quiet.
Okay, good. All right. I'm going to stop recording now.
Yeah.
We found the acinar glands confusing. Yes, they are slightly confusing. That is true.
But it tells us it's eyelid.
Yeah. Okay, I'll stop recording there, and I will. We'll go.
Diane, just
yeah.
on the image that you're in now. Obviously, if you just zoom out a little bit,
Yeah.
is that obviously the fat and the glandular structure, and then just on the outside of that, we were looking at some cells. Can you just confirm what type of cells they are?
These ones?
No, just kind of around the edge of that chalazion or whatever, just to the left of it. Yeah, about in there somewhere.
All right, so this is a mixture of little dotty blue cells, which are lymphocytes, and slightly bigger cells with the elongated nuclei, which are histiocytes.
Okay, so and just up a little bit, if you just went straight up, yeah. So all those those are histiocytes, are kind of longer.
Yeah, the dotty round ones are lymphocytes, and the slightly longer nuclei ones are histiocytes.
Cool, thank you.
So although it's a mixed inflammatory population, I wouldn't describe them as pleomorphic cells. It's pleomorphic in that there is a variety of different cell types, but describing this as a pleomorphic would lead you down the wrong pathway.
Okay.
So one more thing, what saying is that how do you know it's not spacious? Will you get giant cell granule? Giant cell with spaciousness? With spacious?
No, you don't.
Yeah.
In sebaceous carcinoma, the lipid remains in the cells, and so you don't get a giant cell reaction.
Because the malignant cells make it.
Yeah.
And they keep it inside themselves.
The frothy cytoplasm thing.
Hopefully we've got one coming up.
Yeah, sebaceous gland carcinoma and a Merkel cell carcinoma. That's 2 things to find.
Right.
You know,
Okay.
right.
Let's take a short break.
Mm-hmm.
I'll stop recording.
And we'll be back at